autologous stem cell transplantation is really standard of care for patients who are young and fit. And definitely, this is really the treatment which is providing the longest progression-free survival. And this has been shown in different randomized phase 3 trials from different groups, including long-term follow-up. However, unfortunately, we need to acknowledge that auto transplant is not a curative procedure, and these patients are going to relapse after the transplant. This is why the choice of the treatment of first relapse, so second-line treatment or treatment of first relapse, is really crucial, because now we do have some very powerful combinations. And here I think we have to distinguish those patients who relapsed after transplant and have received continuous lenalidomide. And this is the group of patients who would be considered as lenalidomide-refractory. And then you have the other group of patients who may not have received lenalidomide maintenance, or they may have received lenalidomide for a limited duration, so they remain lenalidomide-sensitive and can be re-challenged with lenalidomide. So in this group of patients who are still sensitive to lenalidomide, obviously daratumumab-lenalidomide-dexamethasone, as it has been shown in the POLLUX trial, is really a very powerful treatment option. We do have now long-term follow-up for the POLLUX trial, and the results when it comes to first relapse after auto, for instance, are quite impressive. So this recommendation is definitely very important. When it comes to the patient who are lenalidomide refractory, obviously you need to switch gears. And again, it has to do, because we're focusing on antibody-based salvage treatments, it has to do with the best partner to the anti-CD38 antibody. And here we have the results of the CANDOR trial, very important data in this population, showing that daratumumab-carfilzomib-dexamethasone is a great option. We do have the IKEMA trial with isatuximab-carfilzomib-dexamethasone. If for some reason one would like to give an IMiD, then obviously you need to use the pomalidomide-based combinations, namely daratumumab-dex or isatuximab-pomdex. Obviously, the different populations that were included in these trials, whether CANDOR, whether IKEMA, whether Apollo, the daratumumab-dex, or ICARIA, the isatuximab-pomdex, are different, and it's very difficult to compare. But here I wanted just to highlight the global picture about how to use these combinations for first relapse after transplant. And the key message, in my opinion, is that we should not miss this step of first relapse, because you can achieve in these patients a relatively long progression-free survival, which can be as long or even longer than what we can achieve in patient in first line. So the treatment of this group of patients is quite promising and brings lots of hope.